Bismillahirrahmanirrahim. Assalamu alaikum. This is Masood Alam. I will be host for today's session. The topic for our discussion will be managing GERD with diet and nutrition. Our today's speaker are Dr. Rustam, who is consultant gastroenterologist working in Khan University Hospital, Karachi. And secondly, Miss Memoona Saleem, who is registered nutritionist and dietitian, who is associated with Pakistan Nutrition and Dietetic Society. Please note that we will take questions at the end of both presentations. Now, I would request Dr. Rustam Khan to please proceed with his presentation. Dr. Rustam Khan, please.
Thank you very much. First of all, I would like to thank Gets Pharma for arranging this presentation. And today I will discuss about medical management of gut disease. So I have nothing to disclose. There is no financial interest adherent to this presentation today. And objective of my presentation today is what is the GERD, what is the prevalence of the GERD, what are the etiology of the GERD, how you diagnose this disease, what is management, what are the complications, knowing when to refer to lower the dose of the long-term safety of the PPI, importance of the patient adherence to the treatment. This picture you can see, this is normal anatomy. Here you see that esophagus and connected to the stomach, and part of the esophagus is intra-abdominal. And here you can also see where is the location of lower esophageal sphincter. Then what is the GERD? What is gastroesophageal reflux? Gastroesophageal reflux is a normal physiological process that usually happens after eating in healthy infant and adult life. And you might have seen children regurgitating milk while they are feeding. This is not entirely the disease, but when this regurgitation is more frequent and it is interfering with quality of the life, this is called gastroesophageal reflux disease. Patient may present with retrosternal chest pain, which is also called heartburn. There is a difficulty in swallowing, which is called dysphagia. And at time, patient may have extraesophageal manifestation like laryngitis with voice changes, dental caries, bronchospasm, and chronic cough. What is the epidemiology? How frequent this disease is? A study from Khan University in 2003, which was published in College of Physicians and Surgeons Journal, and that 963 individuals were interviewed, and overall frequency of GERD was 24%. Out of these, 58% was male and 42% were female. A recent systemic review showed that the prevalence of GERD is 18 to 28% in North America, 9 to 26% in Europe, 3 to 8% in East Asia, and 9 to 33% in the Middle East, 12% in Australia, and 23% in South America. This is usual behavior of the patient when they see very spicy and very junk food, because they don't like to take because of the fear of the symptoms. What are the causes of GERD? Number one, when there is an inadequate saliva to clean esophagus, for example, in connective tissue disease and Sjogren's syndrome and Sika syndrome, etc. When there is a motility problem, for example, in achalasia, patient may have GERD. Disorder of the gastric emptying, for example, large meal with increased fat. Condition promote high intragastric pressure, for example, during obesity and during pregnancy. Contributory factors, associated factor with GERD are obesity. Extra weight causes pressure on the stomach and diaphragm and result in a reflux. In peptic ulcer, it causes reflux because food doesn't move from the stomach to the small intestine efficiently. Hiatal hernia, weak lower esophageal sphincter facilitate reflux symptoms. During pregnancy, progesterone level loosen the lower esophageal sphincter, plus gravid uterus exert pressure on the stomach, resulting in gastroesophageal reflux. What are the alarm symptoms associated with GERD? When someone has weight loss, when someone has anemia, difficulty in swallowing, or upper GI bleed, these are the alarm symptoms along with the GERD. How you diagnose the GERD? There are different modalities through which you can diagnose the GERD disease. For example, barium swallow, endoscopy, 24-hour pH monitoring, and esophageal manometry. Barium swallow is useful for diagnostic test with patient with a GERD to look at whether or not there is stricture. Here you see on the left side of the slide there is a stricture in the center of the esophagus. You can see mass lesion. You can see bird beak appearance deformity during when there is a achalasia, and patient may have hiatal hernia, size of the hernia and type of the hernia, whether this is sliding hernia or paraesophageal hernia. But there are limitation of the barium swallow because you cannot see the detail of mucosa and you cannot take biopsy to exclude Barrett esophagus. So next modality of the investigation is endoscopy, and here you can directly see the view in interior part of the esophagus, and you can have option to take a biopsy. And what are the indications for GI endoscopy during GERD? When there are alarm symptoms, when empirical therapy is failed, when you want to detect whether or not there is Barrett esophagus. Barrett esophagus is metaplasia of the mucosa on the lower end of the esophagus when squamous epithelium is replaced by columnar epithelium, which is pre-malignant condition, and in long run they can transform into adenocarcinoma. This is another modality of diagnosing that this disease is 24-hour pH monitoring. This is physiological study. Here you can quantify reflux in proximal and distal esophagus, and symptom can be correlated with the acid reflux in the patient who are symptomatic. Another modality of investigation is esophageal manometry. It has a limited role in diagnosis of the GERD, but it can help in assessing lower esophageal sphincter pressure, location and relaxation, and assist in placement of the 24-hour pH catheter. And before doing surgical procedure, it is important to define that there is peristalsis present in the lower esophagus. Otherwise, if you wrap up lower end of esophagus and there is no motility, then you may end up with dysphagia. What are the complications of the GERD? First and the foremost complication is erosive esophagitis. This is in the endoscopic picture of erosive esophagitis, and there are several different way of classifying esophagitis. There are Severity Miller classification and Los Angeles classification and so many other. I don't want to go into detail, but there is a severe reflux esophagitis seen on endoscopy in this patient. You can have this another complication which is called peptic stricture. Here on the right side you see there is a barium swallow, there is a narrowing, then hold up of the barium, and on the right side endoscopic picture there is a stricture, oozing and bleeding and ulceration also. And these are the modalities of dilating esophageal stricture. On picture A, these are Maloney catheter which are filled with mercury. Picture B is Gilead dilators, and C picture is through the scope dilators, balloon dilators. And these are the demonstration of esophageal dilatation. On picture C, B, and C, you see there is a guide. There is a guide wire passed through these catheter, and when balloon is inflated, it dilates the stricture, and patient's dysphagia is improved. Another complication is mass lesion or cancer. On the left hand in this picture, you can see there is a barium study. You see there is a hold up of barium, there is a shouldering sign, and there is stricture on the lower esophagus. On the right side, this is an endoscopic picture. You see there is a mass lesion. This is transformation of adenocarcinoma on the background of Barrett esophagus we have already discussed. Coming to the treatment of the GERD, there are 5 modality of treatment: diet, lifestyle modification, medicines. In medicine, we have antacids, H2 blockers, proton pump inhibitors. We have endoscopic therapy, and then finally the surgery. So diet part will Memoona will discuss about diet. So I will leave this part, and I will discuss rest of the four modality of treatment of the GERD. Coming to the lifestyle modification, when patient come to us and we make the diagnosis of GERD, we should ask them to take small and frequent meals. Don't ask the patient to take too much at the same time, otherwise it will further aggravate the symptoms. Consume less fat in the diet, maintain an upright posture while eating and for 45 to 60 minutes afterward also. Avoid eating for 2 to 4 hours before going to bed. Achieve and maintain healthy weight. If patient has a overweight, they should lose the weight. When sleeping, raise the head end of the bed for 6 to 8 inches. Avoid tight clothing in the abdominal area and stop smoking. These are lifestyle modification, and we should take our time out to teach and advise the patient. Otherwise, our treatment will be half-hearted. Coming to the medicines, first is the foremost is the antacid, then H2 blocker, then proton pump inhibitor. Antacid, over-the-counter antacids are appropriate initial therapy for GERD symptom. Approximately one-third of the patient with heartburn related symptoms use at least twice weekly antacid. Antacid provide more effective and immediate relief than placebo for GERD. Antacids are not very useful for the severe symptom in severe GERD disease. These are different salt available in the market. Aluminum and magnesium salt is commonly used. If you use aluminum salt alone, it can cause constipation, and magnesium salt cause diarrhea. And some antacids, you have combination of two, where they can antagonize the side effect of constipation and diarrhea of each other. Another group of medicine is H2 receptor blocker. These are more effective than placebo and antacid to relieve heartburn and heal erosive esophagitis. H2 receptor blockers can be used regularly or on demand. Cimetidine, famotidine, nizatidines are H2 receptor antagonists available nowadays in the market, and ranitidine with the name of Zantac, which are recently withdrawn from the market because of its carcinogenic effect. Coming to the third group, proton pump inhibitor. Proton pump inhibitor provide better control of symptom and faster healing of the erosive esophagitis than H2 receptor antagonist. PPI reduce the production of acid by irreversibly blocking the enzyme called hydrogen potassium ATPase, which control acid production. And hydrogen potassium ATPase is also called proton pump, and it is found on the parietal cell of the stomach. This is very important picture. Here you see that there are three mechanisms to stimulate acid production. One is vagus, second is histamine, third is gastrin. And final common pathway is inhibited by hydrogen potassium ATPase. That's why if you give proton pump inhibitor, it block all the three stimulation processes which control the acid production, and that's how these are more potent than H2 receptor blocker or anti-cholinergic medicines. Proton inhibitor available in the market are omeprazole, esomeprazole, pantoprazole, rabeprazole, and dexlansoprazole. PPI are similar in action, and there is no evidence that one is more effective than other. PPI differ, however, by mechanism of breaking down by the liver and drug interaction and duration of action. Pantoprazole has long duration of action and therefore is taken once daily. Dexlansoprazole is new generation PPI and had dual release property. First release of medicine occur within 1 hour and second release 4 to 5 hours later. Dexlansoprazole can be used with or without food. Capsule can be swallowed as a whole, or patient can open the capsule and swallow the content also. And don't forget that every medicine has side effect, and these proton pump inhibitor and other medicines are used as a peanut, and the prescriber should know what are the possible side effect of these medicine. Proton pump inhibitor can be associated with headache, nausea, vomiting, diarrhea, abdominal pain, flatulence, fever, rashes. Pseudomembranous colitis due to Clostridia difficile are associated with proton pump inhibitor. Osteoporosis in long-term use, hip, wrist, and spinal fracture, and vitamin B12 deficiency are also associated with proton pump inhibitor when these are used in prolonged period of time. Interstitial nephritis and chronic kidney disease are also seen rarely with these medicine. Coming to endoscopic therapy, there are three types of endoscopic therapy available to treat the GERD. First and foremost is radio frequency ablation. This is the device. Through endoscope, it is passed into the esophagus, and radio frequency energy is delivered to the gastroesophageal junction, and muscle at multiple sites are, when this energy is applied, there is a reflux barrier is increased. This is another modality of endoscopic procedure, which is called transoral incisionless fundoplication. Here, a device is passed through the esophagus, and this is on picture A, B, C, and D and E. You can see that hiatal hernia is reduced to less than 2 centimeter, and 2 to 4 centimeter length valve is created around to 70 degree circumference of the esophagus. And another modality is called anti-reflux mucosectomy. This procedure based upon principle that after mucosal resection, the mucosa healing result in scar formation, and this in turn result in shrinkage and remodeling of the gastric cardiac flap, while thereby reducing reflux event. Here you can see that scope with the cylinder is passed in the esophagus, and saline is injected in submucosa. Then mucosa is removed by snare, and finally this scar is formed and ulcer is healing. And when there is a spurting of blood, and there are special device adherent to this instrument which can stop the bleeding as well. So these are endoscopic measures through which we can do some supportive treatment to the patient with GERD disease. When to discuss anti-reflux surgery with the patient? This is a very important question. We could keep on pouring in the medicine on and on and on, and very rarely we refer these patients for surgical assessment. When you should refer these patients for surgical evaluation? When the disease is intractable, when it doesn't respond to the treatment. Although this is rarely in rare indication, but you can consider. When patient has a difficult to manage stricture, when there is a severe bleeding from the esophagitis, when there is a non-easing ulcer, when GERD is requiring long-term PPI, when there is a persistent regurgitation and aspiration, and when patient cannot tolerate medicine and doesn't want to take PPI or the other groups of medicine for prolonged period of time. And mind you, Barrett esophagus alone is not the indication for anti-reflux surgery. This is the way surgeon approach the GERD, and here you can see that intra-abdominal part of the esophagus is restored. First, when there is a big gap in the diaphragmatic crura, it is reduced. Third one is this on the cardiac end of the stomach. This is a wrapping of mucosa, wrapping around, and that potentiates the pressure over that area. And then hiatal hernia size is reduced. One and the foremost precaution is to check whether patient is taking the medicine, whether there's adherence to the treatment or not. In this picture, physician is taking oath from the patient that he should take the medicine religiously. This is the algorithm how you approach. This is practical how you will approach the patient with GERD. If patient with GERD has mild symptom, Mild symptom is less than once per week symptom. Initial management will be with lifestyle and dietary modification. This should be repeatedly asked for the patient to take care of diet and lifestyle modification. And then low dose H2 receptor blocker can be used in these mild symptom cases. You can also use antacid with or without sodium alginate. In these conditions, symptoms are less than once per week. Assess symptom at 4 week. If patient respond, that's okay. If patient doesn't respond, or if these symptoms are severe, then you should go to another arm of the algorithm. Lifestyle and dietary modification is also always important. And if patient and this patient PPI is started with once daily dose. If symptom persist, reinforce compliance and lifestyle modification. And if patient still symptomatic, then this is refractory GERD and you should go to another algorithm. This is algorithm is to management of the GERD patient who do not respond to PPI daily doses. So these patients should be treated with 2 month therapy. If they fail to respond, then review the PPI dosing. If a patient is normally taking medicine, you have ensured, but this is not responding, switch to another PPI so that patient may respond to that even. If again patient is not responding to another, then you can go for esophageal impedance and pH monitoring. pH monitoring. If pH monitoring is negative, it means this patient has psychological symptom and you should try tricyclic antidepressant or SSRI or SNRI. If impedance pH monitoring is positive for acid reflux, PPI dosing and time and compliance should be ensured. And if patient still not responding, then you can use H2 receptor blocker at bedtime or sucralfate or sodium alginate and as per required need, and refer this patient for surgery or endoscopic therapy. If this endoscopic impedance pH showed weak acid, then again lifestyle and diet modification and then can be tried. But if patient don't respond, then refer this patient for anti-reflux surgery or endoscopic therapy. On the other hand, if you don't have facility of impedance, empirically start patients on the basis of symptom. If patient have regurgitation symptom, then start them on PPI dose. If they don't respond, then refer this patient for anti-reflux surgery. If patient has heartburn predominant, then start this patient on H2 receptor blocker at bedtime along with sucralfate or sodium alginate. If patient again do not respond, then consider antidepressant, tricyclic antidepressant, SSRI and SNRI. What are the duration of acid suppression? Patients with severe esophagitis or Barrett esophagus require maintenance PPI dose to avoid complication, and patients without severe erosive esophagitis and Barrett esophagus PPI should be prescribed at the lowest dose and for the shorter duration of act. In patient on PPI for longer than 6 months, taper off the PPI dose before discontinuing and can use H2 receptor for mild to intermediate cases or intermittent cases, and discontinues acid suppression medicine when patient is asymptomatic. Approximately two-thirds of the patient with non-erosive reflux disease relapse when acid suppression is discontinued. Patient with recurrent symptoms should be managed with the acid suppression therapy with the medication and dose used previously, or it can be increased to double dose also. In patient with recurrent symptom more than 3 months after discontinuing acid suppression, 8-week course of acid suppression therapy is repeated. acid suppression if patient has a recurrence earlier than 3 months after course of 2 month course of PPI, then these patients should have require long-term maintenance therapy with PPI for acid suppression, but lower effective dose necessary to control GERD symptom. What is the role of H. pylori eradication in the patient with GERD? There is no role of routine screening of H. pylori infection or empirical eradication of H. pylori is not recommended in the patient with GERD, but in setting of GERD when there is a enteral gastritis and H. pylori infection, that should be treated and that improve the symptom to some extent. Few word about management of GERD during pregnancy. Lifestyle and dietary modification should be started first. Ask the patient to keep their head elevated while sleeping. Avoid dietary triggers. And pharmacological therapy can be tried in these patients and start with antacid followed by sucralfate. In patients who fail to respond to H2 receptor blockers or sucralfate, then they can be considered for PPI because PPIs are category B medicine and these are safe in pregnancy also. So in conclusion, ladies and gentlemen, GERD is a common disorder associated with heartburn, chest pain, dysphagia, bronchospasm, and chronic cough. If alarm symptoms are present, endoscopy should be considered. If no alarm symptoms are present, you can consider treatment with PPI straight away without investigating the patient. And if patient respond, that will give you the diagnosis as well. Medical treatment is very effective and nutrition is an important adjunct to alleviate gut symptom. Surgery is recommended for very few patients and treatment for the GERD is lifelong. With this, I would like to thank for your patient listening and we will take question answer at the end of this presentation.
Thank you, Doctor, for having an extensive discussion on GERD. I hope there are so many questions popping up in your mind, but we'll be taking after Miss Mamuna's presentation. Now, I would request Miss Memoona to start with your presentation.
Assalamualaikum. Are you listening me? Hello.
Yes, we can listen to you. Please proceed.
So may I proceed with that? Assalamualaikum. This is Memoona Saleem. Currently, I am practicing as a private. Currently, I am doing my private practice as a dietitian at Al Hafiz Medical and Dental Clinic. Priorly, I have worked in AQU as a clinical dietitian in general surgery and gastroenterology department. In today's webinar, we will inshallah talk about the dietary management of GERD. This is my disclosure statement that I have no commercial financial interest associated with the objectives, content, or delivery of this session. The objectives for today's session would be to discuss the prevalence of GI disorders in our population, then causative factors behind increasing incidence of GI disorders, and therapeutic dietary strategies for treating GERD. Let's move towards our first objective. When we see the prevalence, we found that Pakistan ranked among the top 5 countries in terms of deaths due to digestive diseases among Middle East region. These findings are from a study conducted in Iran for over a 10-year period and found that the rates for diarrheal diseases, esophageal cancer, hepatitis, cirrhosis are highest in Pakistan among all other GI disorders. When we look for the recent data, then we found that there is 30% increase in number of patients with digestive diseases during a 1-year time frame, which is from 2017 to 2018, as reported by the PIMS gastroenterology department. And the diseases which were common in our population include peptic ulcer, GERD, IBD, IBS, pancreatitis, and several other malabsorptions. This is the table which I have shared with you, and this is from the research which I shared previously. If you see in this table, so in this table, all the countries have been given ranking for the diseases which are common, which are prevalent in them. So you see Pakistan ranked 1 for the diarrheal diseases, ranked 2 for cirrhosis, ranked 4 for hepatitis, and third in peptic ulcer disease. So I think all these rates are very alarming and urging us to work for the awareness and education of our people in local communities. So this is something very important to identify that what are the positive factors behind the increasing incidence of GI disorders. So number one, I have included the factors which are related to the diet, and particularly the diet. So number one factor is increased prevalence of overweight and obesity. We all know that the rates of obesity are increasing at a very rapid rate in our country, and one in four of every adult is obese or overweight in our population. Then consumption of contaminated water, which is the main problem. Consumption of contaminated food. A lot of people have the habit of consuming street food, which is not prepared properly, and food hygiene is not considered in preparing those food. So these foods are also a risk, are the main cause. Then improper food hygiene. In my view, I think we need to educate our people regarding the handling of the food, not only on the commercial scale or organizational level, but also on the household level, because people lack this basic knowledge that how to maintain food hygiene at home, or at the institutional level while preparing food for the people to be served. And the most important factor is change in traditional eating pattern. I think this is something which has changed the picture very significantly in the last era. So, what are the changes which came in our eating pattern? So, the subcategories include the family frequency of family meals has decreased, consumption of processed, prepared, and packaged food has increased, eating out, food deliveries became more common, and all of these factors are lead to the outcome that there is increased consumption of energy dense, high fat foods, those foods which are high in salt, and also the decreased consumption of fruits and vegetables, which is taking us towards the more prevalence of the diseases, specifically GI diseases. Let's see the dietary factors that depress immunity. Why we are discussing this? Because the reason is that during the times of illnesses or diseases, people often search for the special diets and supplement to boost their immunity. The important thing which we need to understand is immunity is a complex process, and it does not depend on the any particular, it does not depend only by the dietary factors, or particularly it is not influenced by any specific food or nutrient. So we have to look for the dietary factors which leads to depress our immunity of the body and make us more prone to get the diseases and infections. Number one factor is, if you see fast food energy, the consumption of fast food energy dense foods have become increased, which means people are consuming food which are higher in calories, but they do not provide you the adequate micronutrient which is required by the body. The second factor, if you see in this diagram, is food insecurity. A lot of people have not access to the fresh and nutritious food because of the increasing inflation rates, and they are expensive to buy. Then next third factor is sedentary lifestyle. So obesity is itself an independent risk factor for the for the development of diseases, and the fatty cells produces the process of inflammation in our body. Then restricted diets. Restricted diet means either the person self guided him to the restricted diet and restricted any particular food component in his diet, or either he or she is restricted by someone else, like not to take these foods and eliminate these foods from the diet. So all these factors leads to the poor quality of the diet, and in turn has an effect on the nutrition status of the individual, which leads to the compromised immune function and more tendency of the body to take to develop infections and diseases. And initially, the diseases which are acute in nature, and if they were not treated well, then it will lead to the chronic phase. So what's the key? So what's the key and what we should do in these scenarios? So the key is the healthy balanced diet. It is the only solution to develop the good immunity, to prevent diseases, and to have a healthy body weight. Because the balanced diet provide you with all the essential micro and macronutrients which are required by your body, and helps you to have a good immunity, to have a good immunity and to strengthen your immunity. Next is wisdoms of prophetic nutrition, a preventive approach. Along with strengthening our immune system, we also need to look for preventive approaches because we all know that prevention is better than cure. So I found a hadith and a Quranic verse which guide us towards preventing strategy for the diseases and health conditions. Prophet Muhammad sallallahu alaihi wasallam said, "The son of Adam does not fill any vessel worse than his stomach. It is sufficient for the son of Adam to eat a few mouthfuls to keep him going. If he must do that, then let him fill one third with the food, one third with the drink, and one third with the air." So we are advised to take food only one in the one third portion of our stomach. So what these teaching leads to? These teachings leads us are guiding us to the concept of eating in moderation, right? तो वो जो हमारे पास concept है portion control का, so that concept is emphasized in this Quranic verse and in the Hadith also, and we are also indicated to avoid all the haram product, and I think this is the rule of thumb or the basic rule for the prevention of several diseases, especially gastrointestinal diseases. So this question is commonly asked, that is nutrition therapy integral in treating GI diseases? So I think that it is yes, and it is very much integral because diet has pronounced effect on the microenvironment of the GERD, and because diet can affect the GI mucosa directly and indirectly by altering the GI microbiota. Second reason is that dietary modification improve patient outcome by decreasing the severity of the symptoms which the patient is experiencing. It also prevent and treat the malnutrition or any micronutrient deficiencies that can develop from a GI tract disorder. And it also associated with the reduced cost when taken with pharmacotherapy, according to some studies. So, can we follow a generalized dietary regime for GI disorders? Most of the people think that if they have any GI issues, they can follow the same diet plan, and some diets which are very popular nowadays, like gluten-free diet or low fiber diet and low fat diet. So people blindly following these diets by their own self without having supervision, without having supervised by any qualified nutritionist or dietitian or any healthcare professional. So I think the main thing which we need to understand is nutrition therapy is individualized, and the basic rule is one size do not fit to all. Therapeutic diets, which includes these low sodium, low fiber, low fat, low residue. All these type of therapeutic diets are suggested according to the following. So these conditions are important, and we need to see as a dietitian. We always see the conditions, whether what are the conditions present for the suggestion of these therapeutic diets. So number one factor is we see the disease condition. Second factor, we see symptoms associated with the disease. Third, we see the nutritional status of our individual, of our patient or individual, which is very, very important. And fourth factor is dietary habits. What are the dietary habits of that person? What eating pattern he is following, in order to know कि कहाँ problems है, कहाँ issues हैं, and food and feeding issues, which include any intolerances, or if we already have, or feeding issues, like if he is having swelling problem or any other problem related to the intake of the food. Now move towards our main topic, which is gastroesophageal reflux disease. So Dr. Rustam has already told everything in clear, uh, everything about the disease process, pathophysiology very well. So I move towards my the nutrition intervention. So if we see, it is a very common disorder, and if we see the positive factor, so the two factors which are related to my interest include the obesity. Obesity is a significant risk factor for the development of this disease condition. And second is some dietary and lifestyle factors which need to be changed if we want to uh, decrease the frequency of this reflux events, or we want to reduce the symptoms related with this disease. Nutritional indicators. What are the indicators, like when we have a patient who is already diagnosed with this disease? So what are the indicators which leads to the to the finding that we should give consult to a dietitian nutritionist? Number one is recent weight loss, dysphagia, which include if there is any swelling problem, feeding difficulty, like that, vomitings, impaired oral intake, the patient has very low intake and is not able to eat, decreased appetite, all this comes in this category. Limited food variety, and iron deficiency and anemia, impaired nutrient absorption due to prolonged medication use. We have the medication which are prescribed for the GERD has some drug nutrient interaction. So this leads to impaired nutrient absorption. So we need to see that also, and obesity. So let's start the nutrition care process, like how we deal the patient when the patient come to us in our clinic, and how we start our nutritional intervention. So number one factor in our nutrition care process is assessment. First, we assess the patient, and in the assessment process, we consider anthropometric measurements, which includes height, weight, BMI, percentage usual body weight. Status of of the patient or the individual. Then diet and medication history. This is very important part of the assessment because it tells us about the current medication the patient is on, eating pattern through 24-hour recall or any other dietary tool, food allergies, preferences or intolerances. The patient is already have these issues priorly. Then solving problem. Because biochemical assessment include, we need to see we need to check the lab values for the electrolytes, risk for anemia, iron status, and other testing procedures as prescribed by the physician. So all of these things are included in the assessment process. So diagnosis can be made after identifying problem based on assessment. Common problems include uh, inadequate oral intake, altered GI function, unintended weight loss, food and nutrition related knowledge deficit. Other problems can also be found, but I have only shared a few examples so that you will have an idea okay, after the assessment how we came towards the next step and have have identified the problem associated with the patient or the individual. So, move towards nutrition intervention. Number one intervention is related to meal volume. It has been documented in several researches that increased meal volume is equal to more reflux events. The reason behind this finding is that larger amount of food causes more gastric distension and takes long time to empty from the stomach. So, based on this reason or rational, we recommend that eat less, little and often. So हम क्या prescribe करते हैं? We prescribe small frequent meals. So usually we have this 5 or 6 meal plan in which we have 3 main meals: breakfast, lunch, and dinner, and in between we plan snacks for the individual. Second intervention is related to meal consistency. Studies have also found that increasing meal viscosity is related to decreased reflux symptoms and volume regurgitation. The reason studies behind is that studies have shown change in frequency of reflux events and exit exposure when effect of solid and liquid meals are compared. The data regarding the meal viscosity is somehow inconclusive, but there are several researches which have shown positive result when compared the solid and liquid meals. And from this finding, what we ask our patient or advise our patient is not to take the liquid along with the along at the meal time or along with the food. We ask them to take the liquid in between meals. The third intervention is weight reduction if overweight and obese. I think this is something very, very important, and several studies have shown that it has very good effect, and it is related. It is associated with the reduced reflux events and improvement in the symptoms if when the patient has lost weight. Then there are some foods which are documented, which have the tendency to trigger reflux events, and avoidance of these foods can help the individual to uh, avoidance of these foods help the individual to deal with the symptoms, क्योंकि ये जो है वो आपकी जो symptoms होती है उनको alleviate करने में help करते हैं, reduce करने में help करते हैं. So these foods and beverages include carbonated beverages because they are associated with the distension of the stomach, acidic foods, which include some fruits, fruit juices, and tomatoes, and they produce gastric acid, which irritates the stomach, which irritates the esophageal lining. Black and red pepper is also is associated to irritate the distal esophagus. Coffee uh, and caffeinated beverages. Coffee and caffeinated beverages relax the esophageal sphincter, increase the tendency to the gastric contents to flow back into the esophagus. And chocolates contain a chemical called methyl xanthine from the coca tree, which is similar to the caffeine, and it also relaxes the lower esophageal sphincter, and which causes acid reflux. Mint and alcohol are also associated with the relaxation of the lower esophageal sphincter. So, what I found, these are the triggering foods, but no randomized controlled trial are available to date to support the recommendation to avoid or minimize these foods. I think we need individualized dietary modification trial to draw conclusions. So हम इनिशियली हम क्या करते हैं, क्योंकि हमारे पास कोई ऐसा कंक्लूसिव डाटा है नहीं इस बारे में कि इनको एलिमिनेट करना चाहिए कम्प्लीटली फ्रॉम द डाइट. सो हम ये वाले जो फूड्स हैं वो हम इनिशियली मना करते हैं, बट we add back to the diet by giving trials. ठीक है, तो हम जो है वो इनिशियली जैसे अगर मैंने अपने पेशेंट को मना किया कि आपने अभी टमाटो नहीं लेना, तो जब नेक्स्ट फॉलो अप वो मेरे पास आएगा तो देन आई विल एडवाइज देम टू इंट्रोड्यूस द tomato or to start taking this food and document this thing in your food diary, because we give them a food diary that when you have taken this food, so either it cause any intolerance or any problem, so you have to report it. So if you are facing any problem, so continue avoiding it. But if you found that there is no intolerance associated with any food which you have initially avoided, so then you can resume taking that particular food. Then meal composition, there is no evidence reported to alter the amount of carbohydrate, protein to affect reflux symptoms. So these should be calculated, or these should be planned as per the requirement of that person to meet the body needs. Then foods with a high fat contents should be restricted, and these foods include fried foods and फैटी फूड्स, जैसे हमारे यहाँ मोरगन गज़ाएँ होती हैं जिसमें नहारी पाए और ऑर्गन मीट्स होते हैं. इसी तरह मिठाइयाँ हैं और आपके समोसे और ये जितनी स्नैक्स हैं, पर्टिकुलरली द बेकरी स्नैक्स जिसमें केक्स, डोनट्स, ये तमाम चीज़ें आपकी, ये तमाम फूड आइटम्स इसमें आते हैं विच हैव हाई फैट कंटेंट. Another thing which is important is there is in a study it was found that the people who are regularly using table salt experience more frequency of reflux event. तो आपने जो ना ये भी अपने पेशेंट को डायरेक्ट करना है कि आपने टेबल सॉल्ट जो है वो रेगुलर बेसिस पे अपने खानों में इस्तेमाल नहीं करना है, ठीक है। तो वो जो एक्स्ट्रा सॉल्ट ऊपर से स्प्रिंकल करते हैं, तो दैट प्रैक्टिस शुड बी अवॉइडेड बिकॉज इट्स लीड because this practice is associated with greater osmolality and which in turn increases the gastric emptying time. So this should be considered. Another thing which is important is the use of oral nutrition supplement. Like अगर हमारे GERD का patient जो है वो weight loss के साथ आया and we are prescribing the nutrition supplement to that patient, so care should be taken because the use of oral nutrition supplement is also found to be associated with the more reflux events. Reflux event because they contain a higher concentration of nutrients, and the general recommendation for all is to have a healthy balanced diet. So I have shared the food, some foods which are consumed by our population to have an idea different what we have to consume from different food groups. There are a lot of choices, but I have written only a few choices to just give a rough idea that what we need to consider. So in for the first category, which is milk and milk products, the milk should be consumed, but care should be taken कि balai remove हो, lassi can be taken, but यही बात important है कि yogurt और आपकी जो milk है उसकी balai आपने remove की हो. The simple yogurt can be taken. It is very good if you make yogurt at your home and homemade cheese. I always suggest people to prefer the homemade food items and prepare things at home because जो processed food है वो itself जो है वो बहुत ज़्यादा problem cause करता है. And when there is the issue of inflammation and we want the GI tract to heal, so we should restrict all the processed food items. Then we have meat and other protein foods. So any curry item which is हमारे यहाँ जो भी सालन ग्रेव बनते हैं, it can be consumed along with the like sabzi vosh का सालन, but care should be taken कि it should be prepared in less oil. और अगर आप उनके ये वो है practice है कि बहुत ज़्यादा तेल खड़ा होता है, तो then they should modify this thing. Then all type of dals can be consumed, eggs can be consumed. There is no restriction for any food. Then grains, whole wheat chapati, boiled rice, and all cooked cereals. So one thing which I practiced and also I suggest to my patients is I always told them कि आप नाश्ते में भी if it's possible क्योंकि हमारे यहाँ पराठों की tendency ज़्यादा है, तो if it's possible instead of switching to the white bread, switch to the chapati, and it has very good effects. It has some very good effects. तो आप जो है वो इस तरह से भी बता सकते हैं कि आप होल व्हीट जो चपाती है जो चक्की के आटे की बनी हुई वो ही नाश्ते में कंज्यूम करें और वाइट ब्रेड से it's a better option. Then vegetables, all vegetables can be consumed. There is no restriction, but need to check some vegetables for the tolerance, which include tomato, onion, garlic, and lime. So if the person is having issue with the consumption of these particular vegetables, so we should ask them to avoid for a certain period of time. And this is also this is also the observation that if a food is not tolerant for the first time, तो ज़रूरी नहीं है कि वो सेकेंड टाइम पे भी आपको जो है टॉलरेंस कॉज करे. अगर हम थोड़े दिनों के बाद उसे लेते हैं, क्योंकि जब आपकी कंडीशन जो है वो बेटर होनी शुरू हो जाती है, तो फिर वो टॉलरेंस का इशू भी बेटर हो जाता है उसके साथ. Okay, then fruits, all fruits can be taken except citrus fruits and fruit juices जिसमें दोनों आ जाते हैं. अगर आप citrus fruit का जूस बना रहे हैं होममेड वो भी, एंड इसके अलावा जो कमर्शियल जूस है वो भी आपकी स्किन के लिए अच्छे नहीं है. लेकिन अगर citrus fruit की कंजम्पशन जो है वो आपको प्रॉब्लम नहीं करे तो then they can also be consumed. Or it is also advised that you start consuming these citrus fruit instead of with the meal instead of empty stomach. Then beverages, green tea, चाय हम यूजुअली हम मना कर देते हैं, कॉफ़ी हम मना कर देते हैं because of the potential effect that trigger because they are the triggering foods for the reflux symptoms. So I would advise them to make some दूध पत्ती with little black tea in them. Once I have seen that there is no the patient is not came to me with the severity of symptoms. And barley water. Barley water is something very ideal for these patients because it is anti-inflammatory and it helps to reduce the inflammation of GI tract. And others, all the condiments can be taken except the pepper, which include black pepper and white pepper. Lifestyle modification. Dr. Rustam has already discussed the lifestyle modification recommendations. So I will have a very quick view. So exercise at least 30 minutes each day is important. Wear loose fitting clothes are important to wear. Smoking should be smoking cessation is important. Need to elevate the head of bed to 6 to 9 inches, and you should put a foam wedge under the top part of your mattress because stacking pillows is not effective. And the last meal should be 3 hours before the bedtime. This is something very very important because हमारे यहाँ अब डाइटरी पैटर्न जो है वो चेंज होता जा रहा है, तो उसमें लोगों की जो पैटर्न है वो ये हो गया कि वो लेट रात का जो लास्ट मील होता है वो लेट लेते हैं. तो दिस इज समथिंग विच नीड टू बी करेक्ट और जिसको जो है फोकस करना पड़ेगा. एंड ईट इन अ काम रिलैक्स फेस. Then the last part of our nutrition care process is monitoring, evaluation, and outcome. When we have advised intervention, when we have given plan to the patient, then monitoring is required for the resolution of feeding and swelling problems or any other problem patient is priorly facing, improvement in underlying symptoms, and need to look for any intolerances related to any specific food and what further we need to advise our patient. So this is the quote of Dr. Mark, that food is not just the calories, but it is the information. It talks to your DNA and tells it what to do. The most powerful tool to change your health, environment, and entire world is your food. So be careful with the food, that what selection you are making with the food. Thank you so much.
Thank you. Thank you, Ms. Memoona, for having a discussion on nutritional management of GERD. Now we have a few questions. I would like to ask Dr. Rustam first. Sir, there's a question that what are the factors that can contribute to the severity of reflux as far as structural functional dysfunctioning is concerned?
Okay, thank you. This is a very good question. And in my presentation, I have already told that if someone has overweight, obesity, if someone is consuming high spicy and fatty meal, if there is a history of overeating and there is associated consumption of alcohol and smoking, these are the factors which precipitate and further aggravate the.
एक और सवाल है कि what are the most common reported complications associated with GERD?
Okay, common reported complication is stricture formation and dysphagia. And in long run, patient may develop adenocarcinoma of lower esophagus because with repeated reflux, there is a transformation of metaplasia of the lower end of the esophagus, whereby squamous epithelium is replaced by columnar epithelium along with goblet cells, and these are pre-malignant conditions. And long run, if symptom persists, patient may develop into carcinoma of the cardiac end of the stomach. The stricture and followed by malignant stricture, malignant transformation in the form of adenocarcinoma of the cardiac.
Thank you. There is a question I would like to ask Ms. Masmoona.
Yes.
What are the importance of micronutrient for maintaining the immune system or building the immunity? I mean, we should take it on daily basis or matlab like it would be a
Basic
part of
this
routine.
micronutrient, the importance of micronutrient is vital in building the immunity. And if we are basically, the problem is if we are consuming a variety of foods, so then there is no need to take additional supplements or the meeting the requirement. But if you are on a restrictive diet और आपने अपनी डाइट में जो है वो कोई एलिमेंट जो है या कोई खुद ही से कोई फूड एलिमिनेट किया हुआ है, then there are chances के over a period of 3 weeks you can develop any micronutrient deficiency which is particularly associated with any specific food item. जैसे अगर citrus fruit है, अगर किसी person की जो है वो citrus fruit की consumption नहीं है और वो जो है वो नहीं लेता है, तो then there are more chances that they would develop the vitamin C deficiency in the long run if they are continuously not having these foods in their diet. And in turn, these micronutrient deficiencies will result in the poor body the poor quality diet, which will affect your nutritional status and you will have the weaker immunity.
Thank you. Uh, there's a question for Dr. Rustam. Sir, what is the relation between GERD and H. pylori, which to treat primarily or otherwise?
Okay, H. pylori infection and GERD are two different problems. GERD is the reflux of the acidic stomach content into the lower esophagus, and H. pylori infection is a infection on the mucosa of the stomach. And it has been said that these Helicobacter pylori are have some protective effect on the GERD, and if you have a patient with GERD and associated with there is associated diagnosis of H. pylori infection, whether to treat this patient or not, this is a long debate since long, and authorities has recommended that for GERD symptom, it is if you eradicate the H. pylori, it doesn't improve the symptom, rather than it will aggravate the symptom. But as Helicobacter pylori is a carcinogenic as well, so when we diagnose for this condition, so we are bound to treat it. Otherwise, we may be held responsible for transformation into adenocarcinoma or maltoma. So this is controversial issue, and there are pros and cons of both of these. But if you have a gastritis, and along with gastritis you have Helicobacter pylori infection, you should treat. If you don't have gastritis on endoscopy, and if you found Helicobacter pylori and you have only GERD symptom, it is recommended not to treat Helicobacter pylori. This is so far these are the guidelines, and these are the messages who are followed routinely.
Thank you. There was one question for Ms. Memoona. What is the connection between stomach disorder and weight gain? I mean, diet has a link with stomach disorder.
Yes, okay. Basically, when a person is suffering from overweight and obesity, so it is an independent risk factor for a lot of diseases, including metabolic diseases and the GI diseases. What happens when we have more fatty tissues in our body? So there is more chances of inflammatory process to occur in our body, and these inflammatory processes lead to the development of diseases, which can be GI diseases and metabolic.
Right. All right. Sir, there's a question for you. Uh, is H. pylori responsible for GERD? You have just answered for this question. And what are the safest and effective PPI options for the treatment of GERD? And what are its complications?
As I already discussed that these PPIs are equipotent. Omeprazole, esomeprazole, lansoprazole, rabeprazole are all equally potent, but they are different in their duration of action and how they are metabolized in the liver and how they interact with other medicine. So uh, each you can choose any of them because most of them has equal potency. And uh, second part of question was
What are the complications of PPI?
PPI complication. Long term, if you are using long term PPI, you can have, we have already discussed in my presentation that there is a diarrhea, vomiting, headache, and patient may have a pseudomembranous colitis and osteoporosis and interstitial nephritis. And in the long run, patient may develop chronic kidney disease as well. So when we should consider indication of these medicine, because this should not be used as a peanut, and whenever they are required they should be used. And when the patient is asymptomatically better, you can reduce or withdraw the medicine, or you can change to other group of medicine, H2 blocker for the time being, if patient has mild symptom, to reduce the long-term side effect of PPI.
Thank you. There's one more question. Is surgery a better option than a medical therapy for GERD? What is your opinion about?
Okay, first and foremost thing is the diet and lifestyle modification. Diet, Memoona has already described how you can modify your diet. Lifestyle modification is very, very important, and weight control is very important. And then medical treatment is to start with. And antacids are the easy over the counter available medicine everywhere. These are cheap medicine, but with severe symptoms these are not very effective. Then you have another group of medicine, H2 receptor blockers. These are also used when there's a mild symptom, but when the symptoms are severe, then you have to opt for PPI group. And as we have already discussed, long term use there is associated with lot of complication. But when your medical treatment fails, when there are other indications, when there are stricture, when there are GI bleed, when patient symptoms are not relieved with PPI, or when there is a side effect of the PPI and patient doesn't want to continue with these medicines, then we should consider these patients for surgical treatment. And surgical treatment is again very effective, and because this Nissen fundoplication is a procedure which is done by open surgery or by laparoscopy, whereby gastric cardiac is wrapped up by mucosa, and that potentiate the lower esophageal sphincter pressure, and that help in preventing the acid content to regurge into the esophagus. So as a last resort, when your medical treatment doesn't respond, then you are only left with surgical. As a first choice, you should go for medical treatment.
Right. Thank you. Miss Mamuna Salim, एक और questions है. कि what is the role of spicy food in GERD?
Spicy food trigger the inflammatory process. Na? Like they may cause irritation if there is inflammation already present. And as we know that that reflux of gastric contents causes inflammation in the distal esophagus. So this may related to, and this may trigger the irritation and may cause pain. So it is better to avoid the spicy foods. To help decrease the symptoms और to help ताकि जो है वो आपको itching और इस तरह की irritation के जो मसाइल हैं pain है वो ना हो. It is better to avoid spicy food. Mild spices, I think consumption of food with the mild spices is like it has no harm and you can consume. But as I discussed in my presentation, that black pepper and red pepper is associated with increasing the pain in the inflammation area of the esophagus.
Thank you. One more question is, as far as our population is concerned, what are the easiest lifestyle modification that can be adapted, and how can we ensure patient adherence to it?
Can you repeat your question? You are talking about lifestyle modification?
Yes.
Yes, easiest lifestyle modification that can be adopted.
I think having a regular pattern of exercise is important. The people in our society, if we see, the main problem is sedentary lifestyle. We don't have a daily routine for exercise. We do not go to gym or have any other activity. So it is not important to involve in gym activities, but it is imperative that you have some exercise pattern. Only brisk walk. I think if I'm talking about very easiest way, so brisk walk is the easiest way get involve your body in the exercises, or you can work out at your home also by adopting some exercises which you can do easily at home.
Well, thank you. In last, I would request Dr. Rustam to, if you would like to advise healthcare practitioners, especially general practitioners who are dealing with such patients, uh, with GERD or without GERD symptoms?
Okay, thank you. Gastroesophageal reflux is a common problem, and we usually see in our clinic on day-to-day basis. And most of the patients are not adherent to dietary precautions, and many of them they are overweight and they are smoker and they take alcohol. And these people for these people, lifestyle modification is the first and the foremost thing to follow. Then there are so many effective medicine available. And mind you, these proton pump inhibitors are very effective tool in our armamentarium to deal with patients with gut disease. But take please keep this in mind that these medicines should not be used unnecessary. It should be used judiciously, because everything has who has action has a reaction also, and long term use of these medicines are not without side effect. And frequent monitoring and frequent counseling of the patient is very important, because most of the time they are not taking precaution in their dietary habit, and they are not doing regularly on the anti-reflux measure. And these are the first and foremost thing to ensure by repeated counseling of the patient. And then we have medicine that should also be used judiciously. And finally, very rarely we refer these patients for expert and for surgeon, because at some point in time there is indication that these patients will be benefited from endoscopic procedure, so for surveillance of Barrett's esophagus. And when patient has dysphagia or weight loss or anemia, they should be referred for endoscopic procedure, because if you pick up these complications in early stage, you can serve these patients in better way. Otherwise, in advanced stages, you may not do much for these patients. Thank you.
Thank you, Dr. Saab. Now I would request Miss Memoona Saleem give उनके कोई concluding statement for our healthcare practitioners.
Okay, yes, I think the most important thing which I want to say is that in order to prevent the GERD or all the GI diseases, it is imperative to teach people to have improvement in their eating pattern, because we have seen that there is drastic change in our eating pattern. People have increased consumption of uh, processed food and junk food. They are more happy to get them, and they want them because they have increased shelf life. They are more taste appealing, taste stimulating, and along with that, all these habits lead to the decreased consumption of fruits and vegetables and the food from the natural origin. So the main advice or the general advice would be to try to eat fresh food or the food which you have prepared in home. So that is the best and the healthy diet which you prepared by yourself, because you know how you handle the food in preparing them. So my advice would be try to eat the balanced diet, especially the food from the fresh food and the food from the organic origin.
And last, I would like to thank you for both the speakers, Dr. Rustam Khan and Miss Memoona Saleem, and the people who are watching us. Thank you for your patient listening. Thank you.
Thank you so much.